This is EHJ Today at the Cardiology Update in Davos, Switzerland 2017. I'm Tom Lüscher, I'm Editor-in-Chief of the European Heart Journal, and I'm talking to Professor Catapano from Milano on the ESC Guidelines on dyslipidemias. Welcome.
Thank you, Tom.
So, what are the 10 commandments, as we tend to say in the journal, of the new guidelines? What were the most important changes for practicing clinicians in what you published last year in our journal?
Well, I think first of all we have to reiterate the concept that we stood still with the concept that LDL is the main target in dyslipidemia for therapy. Therapy means lifestyle intervention, dietary intervention, and pharmacological or surgical intervention. That has to be crystal clear from the beginning, because many people tend to think drugs will do everything. That's not true. And we spend a lot of time on the guidelines and space in the guidelines just reassessing the concept of lifestyle and dietary intervention for people at moderate and low risk. This is the main part related to non-drug intervention that has been expanded. The other part that has been widely expanded is the part about adherence and persistence to therapy. This is something we are all aware. No matter what we recommend, people will stay on the dietary interventions, drug intervention for a moderate period of time, and then the benefit will fade away. For example, we know that people with coronary surgery, bypasses, stents, whatever, they will stay on a statin at 1 year for no more than 60%. At 2 years is 40%.
That's terrible.
So that's a terrible point, and you just don't get the benefit you should get with a drug. And that is the second important part. A third important part has been the goals.
Yes.
We have set the goals.
The target levels, yeah.
Yeah. Now we made many people in the United States have argued that the target is what you want to modify. The goal is where you want to go. Mm-hmm. So we have taken that approach. Right. I'm not a mother tongue speaking person, so I take their advice, and we made it that way. Target is the LDL, the goal is where you want to go. Right. And now the goal is still 1.8 millimoles per liter for LDL for very high risk people.
Mm-hmm. Like those after an infarction?
Myocardial infarction, acute coronary syndrome, people with diabetes and another marked risk factor like hypertension or marked LDL elevations, or the presence of plaques in the carotids or at coronarography. And those is 1.8, that is equal to 70 milligram per deciliter. And, but we also introduced the concept or 50% reduction if without any therapy, and there are cases, you start with a level that is between 70 and 140. That's why we want to secure everyone with at least 50% reduction that has been shown to be the point at which you start to regress and stabilize plaques.
Okay, so let's start with the diet. What can we achieve with the diet? I mean, in the old days we said we have to avoid lipids, but now we know that only a small part of the cholesterol is actually taken up from the gut. So what can we really achieve with diet?
Well, the real, speaking of plasma lipid, of course, because there are other things that are related to diet, very important indeed. Sure. The point, you can achieve up to 10-15% depending how intensive you are with the changes. Yeah. What we have learned nowadays is monounsaturated fat are the fat to be preferred. But what really matters in the end is not only the quality, but is unfortunately the quantity. And many people do not maintain the point you should aim not to gain weight. Right. That's the real problem. Because if you overeat, no matter what, will not be good for you anyhow, even if it's a good food.
Yes, and what does a gastric bypass do for those who never achieve the weight that they should have?
Well, there are some studies that just came out recently, although they do not have the outcomes for cardiovascular events, very limited numbers, but apparently they have a profound effect also on lipids, but mainly on insulin resistance. And you know all the circuit with triglycerides and cardiovascular risk.
Now, a question that's very important for clinician is, when do you start a statin? Now, in a patient that has an infarction, acute coronary syndrome, it's quite clear. but let's say you have a 45-year-old person coming with a LDL, you measure the LDL and it's 3.8 or it's 4.2 in this range. What do you do?
Well, again, you have to assess the risk, and you can also assess whether it is in the high risk, not very high. Mm-hmm. And a high risk, you have all the people with diabetes, for instance. Yes. Mm-hmm. So will fall, if the person has diabetes, will immediately fall into that, and you should start therapy. However, while for the very high risk, we suggest immediately to start the therapy together with dietary and lifestyle advice. Under those circumstances, we suggest a 2-3 month therapy with diet and lifestyle, and then start the therapy with the statin. We always suggest the maximum tolerated dose of a statin, just to make sure that people get the most advantage from this. And then we also suggest, as a second line, combination therapy. Of course, the data so far tell us cholesterol absorption inhibitors are the ones which have the evidence, so we can only suggest those. They have an effect,
but it's actually not smashing.
It's moderate. Unfortunately, the trial has been run in a population with a starting level of 69 of LDL cholesterol, which was not the ideal circumstances.
The difference, yeah, exactly. Now, the new door that's opening now is the PCSK9 inhibitor, and we're looking forward to the Fourier trial, obviously, that apparently has been stopped because it met its primary endpoint. What do you think? How is this going to change the field of lipid management?
Now, there are two things to be considered. The first one is purely the efficacy and of the drug. Yes. Those are spectacular drugs. On the top of the statin, you get 60% reduction. Tremendous. Never seen something like that. You can drop down to 10 milligram deciliter, 0.2 millimole of LDL cholesterol. So the effect is spectacular, and basically we expect an effect that, in terms of events, that is proportional to the reduction of LDL. Mm-hmm. However, there are some interesting points there that we can ask as a question. The first one will be, as you know, they do not decrease markers of inflammation.
Yes. Mm-hmm.
And
which is surprising.
Well, in a way.
It shows what Paul Ridke says, that there are two pathways.
Yes, that's the point. But still, I do believe, but that's my personal view, of course, that what matters is the LDL reduction. And we'll see from the Fourier data if they fit into this continuum of the line there. And that was one scientific question, very important to be answered, thanks to this kind of approach. And the second one will be the story about diabetes and statins. Yes. Is that just a statin effect, or is the LDL reduction that triggers that?
It also is not so good for diabetes, like statins a bit.
Right. I mean, Mendelian randomization studies, we have published that paper in New England recently together with Brian Ferencz. If you take the Mendelian randomization approach, also the polymorphism with PCSK9 will put you at higher risk of diabetes. However, when you look at polymorphism, you have a lower level also inside the cells. With the antibodies, you are not having that. Yeah. So we need to see, and we be prepared to possible discrepancies there.
And of course, the last aspect is, of course, the price. And we will see.
Was the second part.
And we will see how this is going to affect.
This is a bit honest. It's a bit.
Yeah. Well, anyway, if it is used and if it's useless, or if it's useful properly, if it's useful and it is costly, it should be considered.
I agree. I fully agree on that. With the right aspect, with the right patient, with the right attack, and then I'm confident that the price can go down.
Right. So let's look forward to this, and I'm sure this is going to change the field enormously, and maybe also interventional cardiology. As less people will come to the CAS lab.
You have to change lab.
Yes. Well, thank you very much for this interview.